Dr. Levine, the floor is all yours.
Great. Thank you very much, Gabby. And nice to meet you all from, albeit virtually. These are challenging presentations to give since I'm just kind of looking at my own slides and myself as opposed to you all. But I'm going to assume that you're all enthusiastic and laughing at all my jokes, and we can hopefully have a little time to have some discussion afterwards. So, okay. There you go. Since this is clinical grand rounds, I thought I would start with a case of a 19-year-old woman who was referred for lightheadedness, palpitations, and orthostatic intolerance. She was previously a highly skilled ballerina, but developed a severe sinus infection while she was on a mission trip. She spent 4 to 5 days in bed, and afterwards, every time she tried to get up, she experienced severe lightheadedness and palpitations, which would resolve when she lay back down. So she spent the next 3 months in bed, stopped going to school, and eventually became so incapacitated that she was confined to a recumbent wheelchair. And this is a picture of her at the time that I saw her, and she had not been upright for more than a year. She had an extensive cardiology and neurology workup, which was completely unrevealing. And when we saw her in the clinic, her supine blood pressure was 110/75 with a pulse of 88. And after 5 minutes of standing, it was 105/95 with a pulse of 160, and she felt terrible. And we'll come back to this case at the end and hopefully I'll give you some follow-up and tell you how she did based on how we approach these kind of patients. So let's start with some definitions. I'm going to show you some data from, or definitions from, excuse me, the American and International Autonomic Societies, in part because I was an author on these guidelines, but they define orthostatic hypotension as a sustained reduction of systolic blood pressure of at least 20 millimeters of mercury or diastolic of 10 within 3 minutes of standing or head-up tilt to at least 60 degrees on a tilt table. Orthostatic intolerance is not the same as orthostatic hypotension. That's defined by the presence or absence of symptoms in the upright posture. Patients may or may not have orthostatic hypotension or tachycardia and still complain of orthostatic intolerance. The postural orthostatic tachycardia syndrome is a constellation of symptoms, in other words, a syndrome of chronic orthostatic intolerance with symptoms lasting at least 6 months, characterized by a rise in heart rate from supine to upright or standing of 30 beats per minute. And if you're less than 18 years old, that line in the sand is 40, or a sustained upright pulse of 120 after at least 5 minutes of standing, with no obvious other precipitating causes of orthostatic hypotension or tachycardia. Now, more recently, since this is a cardiology group, I thought I should at least show you the Heart Rhythm Society consensus statement that Bob Sheldon led, published a few years ago. And they define POTS pretty much the same way, but they emphasize the presence of symptoms that occur with standing, and that's important, and then the increase in heart rate of 30 beats per minute or 40 in the absence of orthostatic hypotension. Finally, syncope is a specific form of transient loss of consciousness and postural tone, which specifically results from global cerebral hyperperfusion, with spontaneous and complete recovery and no neurologic sequelae. When the cause of transient loss of consciousness is not clear, we probably shouldn't be calling that syncope. So let me give you a framework for how I like to think about syncope and orthostatic intolerance. And of course, syncope is fundamentally a brain problem. And it can happen because of something that happens intrinsically in the brain, seizure, acute decompression in an airplane, severe hypoglycemia, but those are usually quite obviously situational, and it really is predominantly an intrinsic brain problem. Now, the brain does have some degree of ability to manage its perfusion. That's the process of cerebral autoregulation. But I have to tell you, cerebral autoregulation is not especially effective, particularly in the chronic state, and particularly outside of the ranges that really are within the normal range of blood pressure. So ultimately, to get blood flow to the brain, you have to have an arterial pressure head. And when that pressure head falls, bad things happen in the brain. So here's an image in the upper right of an EEG on a young woman who had syncope on a tilt table. Down on the bottom is her EEG. She's tilted upright, her blood pressure becomes unmeasurable, and then she has theta and delta waves. And when she lies back down, her blood pressure comes back and she regains consciousness. So the presence of this myoclonic jerking that we often see in patients who have cerebral hyperperfusion is present without requiring a seizure. Any type of cerebral hypoperfusion can cause myoclonic jerking and look like a seizure. So if they faint first and then jerk, that's generally syncope. If they start having seizure activity first and then fall to the ground, that's more typical of a seizure or intrinsic brain disorder. Now let me remind you that mean arterial pressure is a function of three things: the heart rate and the stroke volume, which make up the cardiac output, and then the total peripheral resistance. And that's it, just three things: heart rate, stroke volume, and the total peripheral resistance. So if the mean arterial pressure falls and cerebral perfusion is inadequate, it can only be because of a problem with one of these three things. In other words, the heart rate can be too slow. It can be too fast if there's an arrhythmia, so inadequate contraction. Stroke volume can be low by end diastolic being too low or systolic volume being too high, or total peripheral resistance can be too low. And if you keep those five things in mind, you can almost always understand why someone has syncope. So in an upright human, if I were to be standing in front of you, I would say, standing in front of you, about 3/4 of our blood volume is below the heart. It's actually very difficult to stand up, and humans are one of the few creatures on the planet that stand up on a regular basis. Now, I know this is true because if you cross your legs, like the Dutch have described, you can push blood back to the head and completely eliminate the hemodynamics of the upright posture. You can do the same thing by using an impedance threshold device and using respiratory muscles to suck blood back to the heart. And it turns out that I'm sorry, I'm getting also paged by the CCU at the same time. But if we put someone on a tilt table and hang them or suspend them from a harness, all you have to do is cross your legs, and that can be very effective. And here's an example of a paper from our Dutch colleagues, which looks at time on a tilt table while you're in a harness, like a helicopter harness. And if you stay there for an hour, almost everybody faints. But if you have them cross their legs, essentially nobody faints. And even patients with profound autonomic failure can keep from fainting simply by doing this. It's like lying down while you're standing up. Of course, other conditions can exaggerate this physiology, like heat stress. This picture from Larry Rowell's book shows you that in normothermic conditions, most of the blood is in the venous arterial compartment. But when you get hot, all the blood goes to the skin. And in fact, you can send 8 or 9 liters of blood to the skin under hot conditions. And that, of course, exaggerates central hypovolemia. Now, in order to be able to stand up, humans have to have sympathetic vasoconstriction. And so this is an example of a sympathetic nerve recording. This is a little recording electrode that you can stick in the peroneal nerve as it passes by the fibular head. And each one of these little spikes is a burst of sympathetic activity, which causes release of norepinephrine, binds to alpha-1 receptors, and causes vasoconstriction. And so when you tilt someone up, you increase the number of sympathetic bursts. And so if you do this, people can stay upright. So what happens when they faint? Well, here's an example of a paper from Shi Fu's laboratory, who works with me, which shows arterial pressure and heart rate. Ventilation is in blue, and sympathetic nerve activity in a young woman who's upright on a tilt table. So she's got a good blood pressure, heart rate's kind of high. There's a lot of sympathetic nerve activity. And then after about 20 minutes, she starts to complain of feeling lightheaded and dizzy. and blood pressure starts to fall, you see the sympathetic withdrawal. So you see here a little sympathetic silence, a few bursts, and then a marked reduction in sympathetic nerve activity, along with a steady fall in heart rate. And bradycardia is often, not always, the final common pathway to neurally mediated syncope. Vasosympathetic withdrawal comes first, and then hypotension followed by bradycardia. Now, that doesn't happen all the time. And here's an example in a patient who has orthostatic hypotension without sympathetic withdrawal. So look on the left-hand side of this figure for a minute. His blood pressure, heart rate, and nerve activity supine. When we tilt the person upright, you have a lot of nerve activity, heart rate goes up, but blood pressure mostly stays pretty constant over about 20 minutes or so. And then all of a sudden, blood pressure starts to fall. And you see that sympathetic nerve activity is preserved. If you look really carefully as the heart rate slows, you can see a little bit of space in between the bursts. But we suspect patients like this are releasing large amounts of epinephrine from the adrenal gland, causing beta-2 mediated vasodilation. So even in the face of marked sympathetic activation, blood pressure and TPR are falling. That's why if you ever decide to use beta blockers in neurally mediated syncope, they should always be non-selective beta blockers to block this beta-2 mediated vasodilation that occurs with epinephrine. So I got into this business studying astronauts, and I'm sort of the gravity guy because I study why people can't remain upright on Earth. And in the early days of the space program, one of the most common problems that astronauts experienced was orthostatic hypotension and syncope on return to Earth. And in the space shuttle era, somewhere between a quarter to 2/3 of the astronaut can't stand for 10 minutes after spaceflight. And I want to dedicate this talk, like I do most of these talks, to my mentor and colleague, Gunnar Blomquist, who died now more than 15 years ago. It really was the pioneer in gravitational physiology. And this chapter he wrote in the Handbook of Physiology back in 1983 remains the definitive work in the field if you're ever interested in reading more about this physiology. But what happens to an astronaut when they go up into space? So here's our upright human with most of their blood volume located below the heart, and we throw them up into space. And you see that all this blood that was in the lower compartment now rushes up into the chest. And that's experienced by the astronauts. Their legs get skinny and their faces and upper body get puffy. So it's called affectionately the puffy-faced bird leg syndrome. Now, we always thought that was funny, right? And we laughed about it until just earlier this year when the first evidence of jugular venous thrombosis was published in the New England Journal of Medicine. And here's an example from that paper where you can see the jugular vein and thrombus, quite a fair amount of thrombus burden with no Doppler signal inside that jugular vein. So the shifting of blood up centrally may not be as so benign as we had previously thought. That's a topic for another discussion. So what happens over time? Well, a large increase in central blood volume is sensed by the volume receptors, and you have an acute loss of volume, about 500 mLs or so of plasma volume loss, which is perfectly fine while you're in space. And the adapted posture is about halfway between the supine and standing position, sort of like you're sitting in a chair. And nobody faints while they're in space. If there are any EP doctors on the call, just imagine, for example, what would happen if someone had VT in space. Normally, we count on patients to fall down, but they wouldn't do that if there's no gravity. So it does complicate the assessment of arrhythmic syncope in space. But astronauts are just fine up there. The only problem comes when they come down. And now they're relatively hypovolemic, and they become central depleted and behave as if they're volume depleted. And that is the predominant cause of their orthostatic hypotension. Now, that's the theory. What happens in reality? What happens to this guy when he comes back down? And I could show you lots of different data from different space experiments. I thought I'd show you some from our Neurolab mission on this in the Space Shuttle era. Here's some stroke volume measured in a group of astronauts, each individual in yellow and the mean in white when they're supine at baseline, and then after 5 and 10 minutes of 60-degree upright tilt. And this is the normal physiology, about a 50% or so fall in stroke volume going from supine to upright. These guys are tilted upright, so there's a little bit of a continued drift over time, but this is a very reproducible stimulus. The L-60 refers to 60 days before launch or 2 months before spaceflight. If I do them again 2 weeks before or 15 days before flight, I see exactly the same thing in the same subject. So this is a reproducible finding before spaceflight. But what happens after 2.5 weeks in zero gravity? R+0 is NASA parlance for landing day. And so you can see first that supine stroke volume is down by about 15 or 20%. But most compellingly, upright stroke volume is down by almost 50% on landing day. Now, this is the hemodynamic stress of the upright posture. What about the reflex response to it? Well, let me show you the heart rate data. Here's the heart rate, baseline supine, 5 and 10 minutes of tilt, 60 days before flight. You see virtually the same response 2 weeks before flight. And on landing day, supine heart rate is a little bit higher, but upright heart rate is much higher. Again, almost 50% higher. And indeed, if we've called a 30 beat per minute rise in heart rate as defining POTS, you can say that astronauts, all of them, have POTS after 2 weeks up in space. But given that the heart rate is higher, not lower, and this is not an arrhythmia, they can't be fainting or having orthostatic intolerance because of an inadequate heart rate. So what happens to systemic vascular resistance and, most importantly, sympathetic nerve activity? So here's some of those data from our Neurolab experiment, and I'm going to present these data in a little bit of an odd way for people who are used to thinking about baroreflex function. The x-axis is going to be the stroke volume, and the y-axis is sympathetic nerve activity in bursts per minute. So this symbol is all the astronauts together, their stroke volume and their nerve activity supine before flight and after flight, and upright before flight. You can see a decrease in stroke volume and an increase in nerve activity. What do you think happens after 2 weeks of spaceflight? Well, here's those data where supine and upright post-flight with markedly increased nerve activity in the upright position after spaceflight. But look, it falls exactly on the same line. So this reflex response to sympathetic nerve activity is precisely calibrated to the stroke volume. Now, typically, we don't think of baroreceptors as being sensitive to stroke volume. We think of them as sensitive to arterial pressure. But in fact, it's the stroke volume that determines the postal distortion of arterial baroreceptors and actually is the stimulus to baroreceptor afferent nerves. And how do I know that? How can I convince you as an audience that this is true? Well, what I have to do is make the stroke volume go away and show that there was more nerve activity. So we did that. Dave Markham did this study using patients with left ventricular assist devices. And if you look at the bottom part of the panel, this is a patient with a pulsatile LVAD, one of the last pulsatile LVAD patients you'll ever see, actually, because we don't implant them anymore. But you can see that in the supine position on the bottom left, there's a nice normal blood pressure signal. Notice that it's independent of the electrocardiogram. So this blood pressure is generated by the device, not by the heart's contraction. And sympathetic nerve activity looks pretty normal. When we tilt someone with a pulsatile LVAD up, we have a transient fall in blood pressure, which is restored quickly with increase in nerve activity. Everything looks great. Well, the top shows you a patient with a non-pulsatile device, a continuous flow device. Notice that there's virtually no pulsatile pressure. And even though there's a lot of ectopy here, sympathetic nerve activity is through the roof and increases even more in the upright position. So even though arterial pressure is normal, these mean pressures are the same, sympathetic activity is up. And to nail this down even further, Bill Cornwell took a group of patients with continuous flow LVADs and changed the revolutions from 8,400 all the way up to 10,600. And here's the blood pressure waveform. At a low frequency, you see a nice pulsatile waveform. This is the carotid Doppler and the electrocardiogram. So you see a nice Doppler pulsatile signal and normal sympathetic nerve activity with a mean arterial pressure in the 70s and a 40 millimeter pulse pressure at a flow of 4.4 liters a minute. When we increase the flow, just by increasing the revolutions, you see that our pulse pressure goes down to 24. Mean arterial pressure actually goes up, but there's no more Doppler flow in the carotids, and sympathetic nerve activity goes through the roof. So stroke volume is that predominant factor which mediates the sympathetic nerve response. So it turns out that if stroke volume is so important, how quickly does it change? And this is an old study by Drew Gaffney and Gunner in 1985, where they induced this phenomenon of cardiovascular deconditioning and loss of plasma volume by only 20 hours of head down tilt bed rest. So here's heart rate and stroke volume during lower body negative pressure. Just think about that like increasing grades on a tilt table. So after literally less than a day, stroke volume is lower and heart rate is substantially higher after only 24 hours of head down tilt bed rest. And if you follow that over time, this is some of our bed rest studies, you can see how quickly this adaptation occurs. Here's the stroke volume in our individual group of patients who come in to the laboratory in the upright position. They've got a stroke volume of about 50 mLs. That doubles when they lie down. When we tilt them head down, and that's a way of sort of getting rid of that wedge shape of the human body to more effectively simulate zero gravity, the stroke volume goes up a little more. And then over time, 2 hours, 3 hours, 6 hours, the stroke volume goes down. It reaches a nadir at about 48 hours and then stays pretty constant over that first week in the head down position. When we bring them back supine, we now see a stroke volume that's halfway between the supine and upright posture when they are supine. Now, if I take these bed rest patients and plot our spaceflight data, along with these, you can see that it's a pretty good model. This is our 12 astronauts, upright, supine, and after 2 weeks of spaceflight. So bed rest, it does a pretty good job of recapitulating the hemodynamic response to spaceflight. So ultimately, that set point for cardiovascular central blood volume regulation is lying about 30 degrees in a Barcalounger, about 50% of the gravitational gradient, watching football. I don't know, you guys don't even have a name for your football team in Washington anymore. So, though I can't crow about the Dallas Cowboys performance on Monday anyway. So if stroke volume is so important, what happens to stroke volume after bed rest? And my lab has been extremely interested in this cardiovascular adaptation phenomenon for many years. And one of the first papers we studied, we developed this technique to measure Starling and cardiac pressure volume curves, where we put a Swan-Ganz catheter through an antecubital vein to measure pressure. We use lower body negative pressure to unload the heart. And then we use a rapid saline infusion to load the heart. We use 3D echo to measure volume. So we can measure both pressure and volume during unloading of the heart and loading of the heart with a saline infusion. So this is baseline LBMP beforehand. Now, if you had asked me before I did this study, I would have said that stroke volume was simply going to fall off the same curve. But we found something quite different. That is, even at the same filling pressure, the stroke volume was much lower after compared to before bed rest. Now, for those of you heart failure docs, you may be wondering if contractile function changed. I'm not going to show you those data, but preload recruitable stroke work, among many others, was completely normal. So the mechanism had to be something related to cardiac stiffness. And here's the pressure volume curve. So volume on the x-axis and wedge pressure, or LVEDP, on the x-axis. The yellow line is before bed rest, the white is post bed rest, and you can see that after bed rest, there's this leftward shift of the cardiac pressure volume curve, which becomes most obvious at the equilibrium volume. That's the volume in the heart when pressure equals 0. It's the volume below which the heart has to contract in systole in order to engage restorative forces and have cardiac suction. And that's down by about 50% after only 2 weeks of bed rest. So it's a leftward shift of the pressure volume curve. Now, I showed these curves to my friend John Tyberg in Calgary a few years ago. And he said to me, yeah, Ben, this is just reducing pericardial constraint, that you're not really changing cardiac stiffness. And I said, okay, well, let's go ahead and take these same people. We'll bring them back a year later, and we'll give them a diuretic so that they lose exactly the same amount of plasma volume and unload the pericardium to the same degree. And it turns out that in those individuals, that the curve was exactly the same. That is, you didn't see that leftward shift. So clearly something is happening in bed rest, which is altering cardiac morphology. And to get at that, we turn to cardiac MRI over more prolonged periods of bed rest. And here's an example of a left ventricular mass measured in a group of individuals at baseline after 2 weeks and after 6 weeks of bed rest. They can't even get up to go to the toilet. And you can see a quite prominent physiologic atrophy. This is the opposite of the athlete's heart. Now, I convinced 3 of these guys to stay in bed for another 6 weeks, 12 weeks of bed rest. And what you can see is that with continued bed rest, here's 2, 6, 12 weeks, in every single individual, there's a progressive fall in left ventricular mass. And in many studies over a number of years, you lose about 1% of your cardiac muscle mass a week. Now, obviously, that can't go on forever. The heart doesn't explode with very prolonged bed rest. And to address this adaptive range, I don't have time to show you all the studies, but let me try to show you a group of studies that we've done over the years looking at that adaptive capacity of the heart. So this study puts a number of papers together. The open bar here is left ventricular mass index to allow us to compare people of different size. And so we're calling that 100%. And when you put people to bed after 2 weeks, 6 weeks, 8 weeks, 12 weeks of bed rest, you lose about 12% of your cardiac muscle mass. And it turns out that if you were to look at patients after a spinal cord injury, they have about a 25% reduction in their left ventricular mass compared to healthy controls. So that's probably the floor. And in fact, that's exactly what we see in patients with POTS, about a 25% reduction in LV mass. In contrast, when you do exercise training, and we've also done those studies where we train people for 3, 6, 9, 12 months, you can see an increase in left ventricular mass. And if I look at the lowest atrophy and the greatest hypertrophy over that longitudinal period of time, that's fully a third of the heart's muscle mass is adaptable, plastic, responsive to changes in physical activity. And if I use as an example of the maximal amount, for example, elite runners using the same techniques, there's about a 75% range, 50% increase to a 25% decrease. That's a very large plastic organ. Now, the question then arises, what would happen if I did this while I was in bed? What would happen if I exercised while I put patients to bed? And we've done that study too. And the best exercise, I love rowing. Rowing is probably the best. There are a couple of reasons for it. Number one, it causes the greatest cardiac hypertrophy of any other sport. Rowers have the biggest hearts. You can also do it sitting down. So if I take a group of healthy individuals and I put them to bed for 5 weeks and I measure their pressure volume curves, you can see a leftward shift from pre to post bed rest of the pressure volume curve that's even more prominent than we saw after the 2-week study I showed you before. What do you think happens to the pressure volume curves in those individuals who spend 5 weeks in bed without any exercise? I mean, with rowing, sorry. Absolutely superimposable. So this stiffening of the heart, this leftward shift, is completely prevented by rowing during bed rest. So, and that also completely eliminated the orthostatic intolerance, which we typically see in patients after bed rest or spaceflight. So fix the heart, and then if you have to fill it and make sure you restore the volume, it eliminates the orthostatic intolerance. So I want to turn in the last bit of my talk to thinking about POTS. And for those of you who take care of it, one of the most dramatic manifestations of this syndrome is that it's almost always in young women. And that's been a conundrum that I think has challenged us over the years in asking, why is orthostatic intolerance and POTS more common in women? And probably the answer can be seen in this slide. And that is, this is of course skeletal muscle hypertrophy in a male weightlifter versus a female weightlifter, but it turns out that women have much less cardiac hypertrophy in response to exercise training than men, and women's hearts are smaller than men's hearts even when corrected for body size. And let me show you just a little bit of data about that. Here's some data from Jerry Mitchell's laboratory in Dallas, where they measured the left ventricular mass in grams in a group of sedentary men in the white filled bar, some cross-country skiers, elite cyclists, and elite runners, and the same thing in a group of sedentary women, elite female cross-country skiers, cyclists, and runners. And you can see the pattern is the same. The athletes have much greater body size and heart sizes than the sedentary controls. That's true both in men and in women, but regardless of whether they were sedentary or athletes, the males' hearts were much larger than the female hearts. And even if we correct that or scale it to lean body mass, that difference still exists. So there's something about being female, perhaps related to estrogens and female hormones, that limits the cardiac adaptation and perhaps exaggerates or exacerbates cardiac muscle loss with bed rest. So what does that have to do with POTS, this syndrome that we talked about at the beginning? And as I told you, POTS is defined by a high heart rate standing. And here's some data that I'm going to show you again from Chi Fu's laboratory, which shows the heart rate at baseline during a low level tilt, and then over 40 minutes of 60-degree upright tilt. Men are shown in yellow, healthy women in pink, and then patients with POTS are shown in this green color. And you can see that women have higher heart rates than men, and POTS patients have higher heart rates even than healthy women, and that difference is exaggerated in the upright posture. Well, if you've been paying any attention to what I've been saying during this talk, you will guess the results of this slide, and that is showing stroke volume during that same tilting period, which is a mirror image of the heart rate data. So men have larger stroke volumes than women, even when scaled to body size. And POTS women have lower stroke volumes, even in the supine baseline, which is most dramatic in the upright posture. This is a stroke index of 15 milliliters. That's like the size of a grape. So I would say that this is an appropriate tachycardia. In other words, appropriate for the fall in stroke volume, rather than inappropriate sinus tachycardia, which is a term often applied to patients with POTS. So I think this is normal response to that unloading of the heart in the upright position. And if that's true, we should also see markedly increased sympathetic nerve activity. And here's a few more nerve recordings. You should be used to looking at these by now. The top is a POTS patient. The bottom is a healthy woman. Each one has about 20 bursts per minute in the supine position. And when you tilt them upright, the healthy female has about a 50% increase in bursts. The POTS patient has a 3-fold increase in sympathetic activity. So again, that low stroke volume leads to a markedly increased sympathetic nerve activity, which we think is responsible for much of the symptoms associated with this syndrome. So if I were to relate, just like I did with the NASA studies, the MSNA and burst per minute versus stroke volume in all our individual subjects, you can see that most dramatically, the POTS patients have a much steeper line between sympathetic nerve activity and stroke volume, and their stroke volume is lower. Notice that the whole grouping of the data is pushed to the left, and their sympathetic nerve activity is higher than the controls, which are shown over here on the right. So do I think that there's something wrong with their autonomic control mechanisms? And the answer to that is, I really don't think so. In almost every area that we've tested, their autonomic function is normal. Here's a typical autonomic test of static hand grip to fatigue. And I have muscle sympathetic nerve activity, either in bursts per minute or total nerve activity. Again, in men in yellow, women in pink, and POTS patients in green. Notice that men, here's the hand grip in the shaded area, and then a circulatory arrest where we blow up a cuff to trap the metabolites in the muscle, and then where we release it in recovery. You can see that hand grip to fatigue causes an increase in nerve activity in everybody, in men actually greater than women, but POTS women and healthy controls are completely indistinguishable. Post-exercise circulatory arrest, which stimulates muscle metaboreceptors, is virtually identical, and they recover normally. And it doesn't matter if it's burst per minute or total activity, which is perhaps more correlated with the release of norepinephrine than just the number of bursts per minute. So I think the POTS patients, as best as we can tell, have normal responses to autonomic stimuli. So what about their heart sizes? Well, let's go back to MRI, and if you look at cardiac mass in grams per kilogram, you can see that women have smaller hearts than men. Again, same color scheme, men in yellow, women in pink, POTS in green. So women have smaller hearts than men, and POTS patients have much smaller hearts than healthy women. They also have a reduced plasma volume. Women's plasma volume is a little bit less than men, not as convincingly so statistically when scaled to body mass, but POTS patients, it's much less, about 20% less than healthy women. So if this is, and if I look at this distribution of left ventricular mass, how does that compare to a healthy, larger population? So Satish Raj and I went and looked at the cardiac mass in the Dallas Heart Study for a group of young, healthy women, 268 of them. This is a population-based study where everybody got an MRI, 268 women from age 18 to age 40, and they have, as you'd expect, a nice bell-shaped distribution of cardiac mass with a centering at about 1.8 grams per kilogram. Here are our POTS patients. They're literally 2 standard deviations below the mean with a much narrower range. And to help you remember that it's 2 standard deviations below the mean, we've come up with an affectionate name for a mnemonic for POTS, which we call the Grinch syndrome. Why the Grinch? Because those of you who have small children or have read the book recently will know that the Grinch had a heart that was 2 sizes too small. Now, sometimes patients with POTS get mad at me for making this analogy, and it's not intended in any way to be insulting or to reflect their approach to the world, only to help the medical community remember that the problem is the heart is too small. So I know that you all are very skeptical and you are still waiting for a little bit more proof. So far, I've shown you only associations. So if I'm going to prove this to you, what do I have to do? Well, to fulfill Cox postulates, I have to make the heart bigger, and then the syndrome should go away. So we did that, and we developed a 3-month training program based on how we rehabilitate astronauts after spaceflight. And the key to this whole program is that we start in the semi-recumbent position. We don't let them stand up, even for the first 1 or sometimes even 2 months. We start only 3 days a week at a moderate intensity, and we start semi-recumbent. And over the course of 3 months, we'll increase the duration, the frequency, adding upright exercise, adding interval training, and adding strength training. And we also increase the intake of salt and water to help facilitate the plasma volume expansion, which is typical of endurance exercise training. And if any of you are interested in hearing a more detailed description between Tiffany Van Gundy at the time and one of our POTS patients, you can watch. It's a little bit long, but it's a nice video which goes over the details of the program and from a patient's perspective, what it takes to go through it. But what happens when we put such patients through a program? Well, first thing you want to know is, do we make them fitter? So since I'm not going to have any men in this, what I'm going to do is show healthy women in pink still, and pre-training POTS in that light green, and post-training is going to be in a darker green. So we were able to, in just 3 months of mostly rowing, increase their peak oxygen uptake from 25 to about 28, about 15%. Now, we still were much less than healthy women of the same age, so 3 months was not completely enough, but we clearly made them fitter, and we also made their hearts bigger. So here's all the individuals and the group data where there's a highly significant increase of about 15% in left ventricular mass, which didn't quite achieve the left ventricular mass of healthy controls, but was increased in virtually every single patient. And we also increased their blood volume measured by the carbon monoxide rebreathing technique. Again, increased in virtually everybody, not quite to the level of healthy women, but increased clearly over the course of 3 months of training. So I've made them fitter, I've made their hearts bigger, I've expanded their blood volume. What did that do to their POTS? So here's the data. And now I'm showing the supine data in yellow and the upright data in green for POTS patients on the left and healthy women on the right. And you can see what I showed you before is a much larger rise in heart rate in POTS than in healthy women. What happens after 3 months of training? You have both a decrease in the supine heart rate and a marked decrease in the upright heart rate, to the point where 2/3 of them were in remission. I use the word cured quite loosely. 2/3 of them no longer met definition for POTS. How about their sympathetic nerve activity? Here's an example of a patient who pre-training had a tripling of her sympathetic nerve activity from supine to standing. And post-training, there was a small decrease in supine nerve activity, but a dramatic reduction in upright nerve activity. And perhaps most importantly, this combination of a lower heart rate and lower nerve activity made them feel better. So this is the SF36 physical score, and a higher number is better. And you can see that every single person felt better after doing their 3 months of exercise training. There is no other medical therapy that gets you results of this magnitude and this consistency. Now, many physicians use beta blockers to treat patients with POTS, and I told you need to use a non-selective beta blocker. So we did a randomized, double-blind, placebo-controlled trial in these same patients who did exercise training. And here's those data. So at this time, the color scheme is a little different. We have the supine data in blue and the standing data in red. And you can see a large increase in upright heart rate, which was reduced by exercise training. And of course, beta blockers also reduce both supine and standing heart rate, where placebo doesn't do that. The only problem is it doesn't make them feel any better. So although everybody feels better after exercise training, even though the heart rate, both supine and standing, is much lower, nobody feels any better after beta blockers because they feel so fatigued, because you're abolishing that appropriate tachycardia. And very few people feel better on placebo. And the same thing is true with the social functioning component of the SF-36. Now, one of the criticisms of this study was that all this was done under carefully controlled circumstances in my laboratory. So subsequently, we did an international registry to see if we could administer this intervention outside of our laboratory center. And we recruited patients from all over the world, mostly in the United States, but also in Europe and Australia. And we had 251 patients from around the world. 90% of them were female. And we did have a large dropout rate. All the doctors did was tell us they had a patient with POTS, gave us a stand test data, and we sent them the protocol. That was the only interaction we had with them. But we still had about 100 of them who finished the 3-month training program. The standing heart rate went from 123 to 100, and the change in heart rate went from an average of about 40 down to 23, with 76% of them, in fact, even better than in our controlled laboratory study, were in remission. And their SF-36 physical function score, everybody went up. So the point is, we can administer this program outside of our laboratory in a doctor's office and get equivalent results. Now, this is still only a 3-month program, and we were able to get data on a few people, about 22 of them, a quarter of our N, who continued the program for a full 6 or even 12 months. And you can see that there's no recidivism, there's no loss of that reduction in standing heart rate. So it's persistent even out